I'm Debbie Stenberg, and today I've got my McKendree University hat on, but we're going to talk about something that pertains to us. You'll hear a lot, have heard a lot about USP 800. We're going to hear a lot more about it. And this is a little introduction to it, but what the USP is the United States Pharmacopeal Convention, Chapter 800. So it's just USP 800. It's easier to say. Okay, next. So what is USP 800? Next. Okay. This deals with hazardous drugs and how we handle them and take care of them. Hazardous drugs can cause harm to people when you're exposed to them. They have, in this regulation, they have these properties, and then the criteria for labeling any new drug is that they can cause cancer or birth defects or problems with pregnancy or reproduction, or cause toxicity just as if you were taking chemotherapy, or they can change your genetic, just as chemotherapy can, your genes, and cause abnormal genes and function. Okay, next. So a little bit of history. We've all, well, we don't all, we have a new girl. But we've worked at this for a while, most of us. About 30 years ago was the first time they tested, and they found that some nurses' urine was positive for some mutated genes, and that they'd been exposed to a hazardous drug. So what happened after that was that the pharmacists, the American Society of Healthcare Pharmacists, made some guidelines then to protect, because people were exposed to it and they were having these problems. And then they updated it through time. Then the OSHA, the Occupational Safety and Health Administration, and the ONS, the Oncology Nurse Society, they developed some guidelines in the 80s as well. And then the National Institute of Occupational Safety and Health developed some guidelines they're correlated with the CDC, and they made an alert and some guidelines suggesting safe practice. But these were sporadic, and not everybody was following them, and this was as they were learning what these drugs were doing and how to protect people from them. Okay, next. So then as time went on, the Joint Commission got involved, and they're not so much, they're more concerned with patient safety, but also they're kind of fallen into place with these other guidelines that other people have made and came up with. Well, then this United States Pharmacopeal Convention set some standards and that's what they do, is standards for quality and purity of medications. But they developed this Chapter 797 in 2004. But this is a pharmacy. They deal with pharmacies, and so they dictate what the pharmacy does and drugs. So they really don't have anything to do with nursing. So they developed that, and they have standards, and that's how in our pharmacy they have hoods and the way they have to store the drugs and protect themselves. Well, then after that came along, the next chapter was 800, was finalized in 215, and it was to be out some months ago, but then it had to be revised because people, mostly because of the cost involved, of the changes it would make and those kinds of things, and so they reworked it, and so now it's going to come into effect December 1st of 2019, and it's going to be the first time that a pharmacy excuse me, company or a pharmacy that deals with their regulations has any say-so about nursing practice and what we do. And the important thing here also is that prior to all those other people that made all those other guidelines, nobody enforced it. If the ONS or somebody said, you know, you have to wear gowns and you have to do this, but there's a lot of places that do not. and they can't, the places won't provide the protection, or maybe it's not the right kind of protection, or people aren't trained, and so on and so forth. So this is a new thing, and now all these guidelines, and a lot of them are going to stay as they are, but they're going to be enforceable, so there's going to be a lot of stuff. Now, where we stand here, Kathy, our pharmacist, is working on the 797, and that deals only with them. And then we've done a few things which we'll talk about, but then we'll start to have some more policies and things for the next chapter 800. Okay, go ahead. So why does this matter? Well, why is it important? Because here we've been fortunate enough to have gowns and gloves and training, and we've taken it upon ourselves to participate in the ONS and learn, and we have our certificates and so forth. But come to find out, even using PPE, protective devices, that when they do the wipe studies, they wipe and then they take it to a laboratory and test. There's still contamination when they test workers that work with these drugs. There's still contaminations, and oddly enough, surprisingly, those employees that have tested highest sometimes are those who are not actually handling the drugs, such as clerks and housekeepers and people that transport and those kind of things. They've had just as high as exposure. So clearly there's something that means that people are still being contaminated even when they're taking precautions. Okay. So the purpose of our talk, I'm going to tell you a little bit of that stuff first, is to kind of introduce you and let you know a little bit about this USP 800 and the standards it sets for safety and with these drugs. And it's this chapter 800 is designed specifically for them to keep those people that deal with those drugs safe, and it's for their safety. So we want to learn, we want to keep our patients safe, we want to keep staff safe, we want to keep ourselves and the environment too. And we in our position, because not on the medical surgical floors and on the emergency rooms, maybe somebody on chemotherapy comes in with that's been on chemotherapy or a pump or whatever, and here it is, and they won't know what to do. Or even patients who have recently been treated that have it in their system, they'll be exposed to, maybe they're sick and body fluids and whatever. So they need to know what to do, and we'll be kind of the teachers of that, as well as the people who clean and all those kinds of things. And we want to increase our compliance in doing the right things the right way with the protection and the devices and those kinds of things. Next. All right. Now, despite all of those things and these things available, compliance, there's still a big problem with compliance of people, not necessarily just nurses, but nurses too, that they know what these drugs can do, and they know what they need to do to prevent contamination, but they don't do it. Maybe they don't want to wear their gown, or maybe they don't want to put on 2 pairs of gloves, and we're all guilty of that. But so we need to encourage people to take the proper precautions, and there will be monitored now with this. Now that this is guidelines are mandatory, they'll be monitoring, and I don't know that, I'm not sure how all that will come into play, but anyway. Next. So we're going to talk a little bit about the protective equipment. Gloves. We're supposed to wear double gloves, which mean you put on 2 pairs. I'm not going to open them up. They're not considered chemo safe or hazardous drug safe unless they have the ASTM and then number standard, which means they conform to the American Society for Testing of Materials, which we had some other gloves which did not have that marked. So that's why we've got these. And if you go, it doesn't matter where you go, if you don't stay here and go anywhere, if you if you do this work and you don't see that on you, then your gloves are not what you should have. Gowns. Gowns shouldn't be cloth. They should be disposable. You don't want to reuse them. Don't wear them out of the unit. They shouldn't have seams. They should be coated so that liquids can't get in. Knit cuffs or elastic. Oddly enough, though, there is no standard for gowns, so you kind of have to look and use your head and say, well, is that really protecting me or not? And long sleeves. Respiratory protection. It's not really recommended that we wear masks when we administer these drugs. More for spills. Full-face chemical cartridge respirators for spill cleanup, or the powdered air purifying respirator for hazardous drugs is used for a large area of spills, or there are some drugs that when they're spilled, that they make vapors come off, and so that would be what you'd use for that. Okay. Some more face protection. We don't really have to wear that for administration, but we do have it. These things are available, and goggles in there if there's a risk of spill or splash, or particularly if you had to do something, which I guess if you had a bag that you had to do something with up there. And again for cleaning spills. Well, so who should wear these kind of devices? Anybody that handles these drugs, these hazardous drugs that are exposed to treated patient body fluids, cleans an area that's contaminated with these drugs, these hazardous drugs, or patient body fluids. Now, that takes into a lot of account from the time for about 48 hours. So if we treated somebody in our department, but then they got sick and went to the floor, so they would have to take precautions, or if they got sick in our department, or housekeeping or environmental services that are cleaning, because there's vapors that can come out of these things, and little drops of things, and they get there, and we don't necessarily always know that it's there. So and this is kind of standard practice, and we've learned all this when we've learned how to administer these drugs, but the amount of protective equipment worn is based on our risk of exposure. You wouldn't have to put on everything if you're going to give somebody a chemo pill. But maybe if you had to cut it or alter the dose in some way, you would have to put on more. Or, if you're going to somebody is having surgery, and maybe they're having it instilled into their body, then you'd have to have protection all over. So it varies. When you get done with all of these things, you take them off and you put them in the same containers that's designated where you would dispose of the equipment you use to administer the chemotherapy or the hazardous drugs. Can't remember. I think that's it for that. Go ahead next. One thing that we've changed is what they call closed system transfer devices. We've had some other Lurlock things, and apparently, and I didn't write all that down because it's too much, but I think like Cytoxin and the carboplatins and some of those, that they're those things, even those Lurlock things that we had before allowed a little bit of vapor out, and these are supposedly to stop that. Go ahead. So this is what these devices do. They block environmental contaminants so that vapors and things can't get in there, and they're not able to release the hazardous drug or vapors created by the drug into the system. They've been a recommendation for a long time, and now this is a requirement. We have to do it. There's then that helps prevent contamination, because of where these bags and things are connected, where those connectors were, then little bits of vapors could get on the bags, and so that then you could be contaminated because you think, oh, it's just the bag, there's no medicine there, but yet the little bit has escaped and got out. And syringes as well. Oddly, there is no standardized testing for those either. So, yes, they're effective, and there has been testing, but there's no, like the gloves, there's no standardized uniform testing to make sure that they're absolutely 100%. So none are foolproof, and even though they were tested, sometimes there's stuff that doesn't work right. And so you can never, ever take that as a substitute. Well, it's got that device on there, I don't have to wear gloves, or I don't have to do this or do that. You can't rely on that stuff. There's hundreds of different kinds of them. There's lower lock ones, I think that one is, and there's with membranes. So it depends on what kind. They don't recommend any kind over others. It's just whatever works with your equipment and tubings and all that kind of stuff. And that's how we choose. So there may be more of those to come too. Okay. Okay. Based on these wipe test studies, and what they do is go in and they have special cloths and they wipe areas, and then they take them back and test and see that what's on there. And they've done many of these, so they found that the contamination is present and it's there. And despite a place using all the guidelines and doing all the things right, it's still there. Hazardous drug residue and contamination can linger for a long time, much like a germ or something. So even though, maybe last week somebody received a certain drug, but it can still be there if it wasn't cleaned well and then neutralized. It could still be there for a long period of time. And alcohol, cleaning with alcohol doesn't remove it. So a solution of sodium chloride, which is kind of bleach, strong bleach, can neutralize some, but it isn't practical. That we can't just go around when a room full of patients wiping stuff off with strong bleach, because we'd all be sick from the fumes and from the bleach. So there are some chemical products that do neutralize hazardous drugs, and they're included as part of the spill kit. But the packages are small, and the problem is that for a larger spill, then that becomes an issue, that there's not enough to neutralize it. And then the last thing, and then I'm going to look at a couple of these things, that don't randomly, if somebody's, there's a chemo spill, don't come and put, let's put this, say some ammonia or this cleaning product or that, because you don't know what kind of a thing it might make more vapors and be worse. So these are, this, I didn't want to bring a spill kit, but you guys can, Jennifer doesn't know, but kind of this stuff in a spill kit. And there's a procedure for that, which she's going to learn, that we've learned. And then this is those things they're talking about. And this is, there's two products. This is the one we have, which is one of them, and there's two steps. This is a bleach, and this neutralizes it. But this only cleans, so you have to be aware of what you're, this treats an approximate area of 2 square feet. And then you do this one and you do that one. So if you've got, that's fine if you've got less than that, but otherwise that's not going to get the job done. And, let's see, okay, go ahead. So the other thing I wanted to say a little bit about was compliance and education. Policy and procedures are going to be developed. We talked a little bit about that earlier this afternoon. We don't have a lot of policies and procedures because we're kind of been evolving and becoming more in line with the guidelines and things in our department. But there's going to be a lot some of this stuff has got to be spelled out clearly. Not necessarily different, but we're going to have to put it onto paper, what we do in our practices. And it has to coincide with what the guidelines say. Some problem has been that some facilities have made these wonderful policies and procedures, but the guideline says to do it this way, and so they're not doing what they need to be doing. And so also these things need to be tailored to individual facilities and departments, because obviously if we don't have the staff or the people or the equipment to do things a certain way, then it would be pointless to make our policy to say that that's what we're going to do. Like I said, much of what we do is not going to change at all, but it's going to be more policies. There's going to be systems, which I suspect will be the performance improvement stuff and monitoring that we'll have to track to say that, we've done this and that we're following what we're supposed to be doing. One big thing they talk about a lot in this USP 800 is that every facility has to develop their own list of hazardous drugs. Not all hazardous drugs are oncology drugs. There are some that are not, but they have to meet that criteria that I showed you to start with, and then we develop a list, and then we have to update it and add as we go along. And sometimes new medicines come out and they may not be considered hazardous first, and as time goes on, as people get to learn more about them, then they get added on to there. But we have to make this list, and we have to identify the precautions we're going to take when handling them. If it's a pill, maybe we don't just need to put a glove on. If it's an IV, then we probably need to put the gowns and the whole deal on. Or if it's something that would be a vaporizing thing, then we'd have to put masks on. Okay, so another important thing is that nurses have to be educated on safe hazardous drug practices prior to administering these drugs independently, which means they can learn, they can work with somebody who is and learn, but until they are trained, then they can't do it by themselves, which is kind of what again is something we've done, because we've taken the training and we review that with our certificates. Now we're going to have to do competency assessments yearly, annually, and keep that information as well. And it's important that the facility, that we have access to accurate information, that we're not doing the wrong things. We need to know what the guidelines are so we can be doing what the guidelines say, and not necessarily what the facility thinks we should be doing. And then another important thing is, I said a little bit, we're going to have to work together, particularly with the pharmacy, but other departments too, because we'll probably play a pretty big role in how teaching other people how to handle these drugs and what to do. I know we've had patients that have been on the floor after treatments and things that I know precautions were not taken, and so we're going to have to help them to learn how to do those kinds of things so that nobody has to be exposed to these drugs. Thanks. So, in summary, hazardous drugs are any drug that can cause harm to anybody that's exposed to them. About 30 years ago or so, different people took their time to devote to training us and telling us, and a lot of, for example, even the nurses that work on the floor, they don't have access to that training. So we're ahead. They're going to have to learn, and we're ahead of that. Let's see. I told you that this USP Chapter 800 was released, and now we have to be fully compliant by December 2019. It's by a pharmacy organization, and it directs a nursing practice, and it's enforceable now. It's important because employees have been continued, even those using protection, have been continued to be exposed to these hazardous drugs and have had adverse effects. And the problem is still that even though people know that there's hazardous drugs and there's bad effects, that they still continue to don't use the protection as they're supposed to. We talked about all the protective devices that we have for the most part and how to use them when generally in the closed system transfer devices so that vapor and stuff can't get out of the syringes or the tubings. Okay, next. These drugs are present and the contamination remains even though we don't think it's there and we think we do a good job cleaning, it can stay there and linger there. So we have to get better with that, and they have to be neutralized. Even if you had a spill and you wiped it up, it's really not considered neutralized and not active unless you use a product like that. We're going to have a lot of policies and procedures. A lot of things aren't going to change, but it has to be written down and shown this is what we're doing. And then in compliance with that will be monitored. Each facility has to develop their own way of their own list of the hazardous drugs and handling precautions. We talked about that. Nurses must be educated, and staff, not just nurses, with accurate information on safe handling practices for these hazardous drugs prior to giving them independently, and then we have to make sure that we remain competent, and also ongoing education, because sometimes as drugs change and practice changes, then we don't necessarily, we have to learn that too. And then this is going to require a lot of collaboration between departments to keep everybody safe and not exposed. I brought this, but I'll keep it upstairs that you guys can look at. This is the actual thing, and it's pretty word for word it wants it to be done. This way, and it spells everything out, but this is the actual thing. Answer your questions. Anybody has a question? Yes, Carla.
Well, years ago, we were all given this in-service thing, like how not to use patient's urine and when to come in for chemo treatments onto the floor. How come they stopped it?
They didn't. On the floor, I don't know. I don't
know what I mean, because we used to, they used to say stuff like, we were supposed to do. I know we're the chemo department, that doesn't pertain to, but I mean, like, some of us knew that they were chemo patients and we'd say something.
I don't know, but that's part of the problem, and that's part of the cracks that people were falling through. I don't know why that happened, but this is to help prevent that.
So there's actually going to be something on the patient's chart that's going to red flag it when they come in there.
Yes, it should be, and we may have to put, there would be a lot of things, like we probably need to get a sign on our door that says hazardous drugs administered here. I know the pharmacy has to have one, different stuff like that. There should be. I know we had somebody not very long ago that they went and they had no, and they don't understand that, which I understand. They don't know what we know about these drugs, but they're still getting exposed to it if that patient is sick.
I mean, I know you guys probably tell the families too, of the patients, right?
Well, it's in our teaching when we teach our patients, but even we can do the best teaching and tell all our patients, but this, people, I went today to St. Louis and got a chemo treatment, and I live in Murfreesboro, and so I drive through it. Oh, I get to Chester and I can't. I'm just sick as a dog and I can't. Well, you can't. Well, I've had the treatment. They don't. People could all over. It's not just our patients. They can come from anywhere. So and that's how people were getting exposed and falling through the cracks that people didn't know. And like I said, we know because we deal with it, but they don't, and I don't know why that is. But this is meant to help correct that. and prevent that. And another thing I forgot to say too was, one thing, like I said, a lot of our policies would continue the surveillance of people who handle these drugs, pharmacy people and us, the surveillance of, you know, yearly physical. Did you have to do that? I don't know. I think we did. I don't know if you did. Did you do one too?
What are you talking about? What, I missed what you were.
I think, remember, we had to fill out those physical, and Dr. Craig
Yes,
signed
we
them
all had
annually.
to.
Did you, did
We
you
all
did-
had to,
you did,
yeah.
okay.
Yeah.
So, okay, that's not, stuff like that that we're already doing, that's gonna continue. That was, I wanted to say that and I forgot that, but yeah, that's,
So I asked if you had any exposure,
yeah,
and we hadn't had any
yeah,
spills. We've only had
Spills.
one in the, that was in the old department.
yes.
That was
that's-
with Kevin.
Yes, I remember, and we're fortunate, but stuff happens, and you have to know with these spills, it's likely not gonna be a nice little puddle on the, you know, the patient's got their stuff all sprawled out, and it's gonna be, so you gotta kind of think what you're doing when you deal with that. It might be equipment that's involved, or, you know, maybe they've got a cell phone or a book, or you've got to figure out how to deal with those things, because they're all considered contaminated. So that's I mean, there's a process to cleaning a spill, but it's not just as easy as, oh, there's a little puddle and cleaning it up. So it takes a lot of thinking to do that, to protect yourself and them and the environment.
That's it.
Okay, good.